substance use and addiction. According to the National Survey on Drug, Alcohol Use, and Health, a big survey conducted by the Department of Health and Human Services, approximately 21.5 million Americans meet clinical criteria for having a substance abuse disorder, or about 8% of the U.S. population. About 1 in 10 Americans report having used an illegal or illicit substance in the past 30 days. Alcohol and nicotine addicts actually significantly outnumber addicted users of illicit substances. There are an estimated 17 million people with an alcohol use disorder in the United States, compared to only about 7.1 million with an illicit drug use disorder. Tobacco isn't actually counted in these addiction stats, but about 66.9 million people identify as smokers, about 3 times the number addicted to all other substances combined. The most commonly used illicit drug by a long shot is marijuana, although its use is no longer even illegal in all states. What about the most deadly? Which drugs cause the most deaths, mortality, or diseases and injuries, morbidity? That's easy. It's tobacco and/or nicotine, again followed by alcohol. Smoking, according to the Centers for Disease Control, is responsible for nearly 500,000 deaths each year, the leading cause of preventable death in America, whereas alcohol, from a range of causes including automobile fatalities, overdose deaths, and diseases of long-term alcohol abuse like liver cirrhosis, kills about 88,000 Americans annually, higher than the estimated 66,000 who died of illicit drug overdoses in 2016. For Americans who admit to using some illicit drug within the last 30 days, marijuana is by far the most frequently used. About 80.6% of drug users report use of marijuana, and about 64.7% report use of marijuana exclusively. This is followed, but fairly far behind, by illicit use of prescription drugs, opiate painkillers, for example, cocaine products, hallucinogens, inhalants, and heroin. Males are more likely to admit to illicit drug use over the past month than females, 11.5% compared to 7.3%. And college students tend to have higher use rates than the general population. However, that might be a function of age. People between the ages of 18 to 20 tend to use at higher rates than other age groups. However, overall, education is negatively correlated with drug use rates. For college graduates, the use rate is about 6.7%, compared to high school dropouts who use at rates of about 11.8%. The National Survey on Drug, Alcohol Use, and Health break their data down by race and ethnicity as well. Again, this is past month use of any illicit drug. For Asians, past month use stands at about 3.1%. For Hispanics, it's about 8.8%. For whites, 9.5%. For blacks, 10.5%. And for American Indians and Alaskan Natives, about 12.3%. Native Americans have some of the highest abuse rates, with populations living on reservations having higher abuse rates than those that do not. The reasons for this are likely based on a number of correlated social problems, including high unemployment, high rates of poverty, culture loss, and higher rates of depression and mood disorders. Blacks and Hispanics are sometimes culturally stereotyped as using drugs at higher rates than whites, but in fact, that's not true. Blacks only use at slightly higher rates than whites, by 1 percentage point, and Hispanics use at lower rates. Moreover, the fact that blacks use at higher rates than whites is down almost entirely to marijuana use. For most other illicit drugs, besides marijuana, whites tend to use at higher rates than blacks, or equivalent rates. We will see this on the next slide. This chart comes from the same data set, but asks respondents if they've ever in their life, even once, used any of the following specific substances. For cocaine use, we see Native Americans with the highest self-reported use rates, about 21.3% of respondents saying they've ever tried cocaine in their life, compared to about 17.1% of whites, slightly under 10% of blacks, 10.7% of Hispanics, and about 3.6% of Asians. For cracks, Blacks are slightly more likely to use than whites, but only slightly. About 5% of blacks in the sample and 3.4% of whites admitted to ever having tried crack, compared to 1.8% of Hispanics, about 1% of Asian Americans, and about 9.5% of Native Americans in this sample. Prescription opiates tend to be more likely to be abused by whites than any other racial group. Finally, heroin, with much lower abuse rates across racial groups, tends to be abused in equal measure by blacks and whites, with again Native Americans admitting to having tried at some point in their life at slightly higher rates. If blacks are slightly more likely to admit to the use of marijuana than whites, though, they are significantly more likely to be arrested for it. These data from the Washington Post on the left show last year use of cannabis among blacks compared to whites. We see a few percentage points difference in most years, but the data on the right tell a very different story, showing arrest stats as reported by the FBI. Almost half of all drug arrests are arrests for marijuana, so it's instructive to look at the extent to which groups of different races are arrested for it. These charts, this data, show us that despite not using the drug at much higher rates than whites, blacks were almost 4 times more likely to be arrested for marijuana possession than whites were. How harmful are different kinds of illicit drugs? It can be a complicated question to answer because any calculation must include variables like total loss of life, long-term morbidity, and the likelihood that use, sale, or trafficking will result in the commission of other crimes. Probably the most detailed and methodologically rigorous recent measure comes from a British study that polled experts in addiction and had them rank the potential harmfulness of popular drugs based on 16 criteria. Some of these criteria measured the potential for harm to the user, him or herself. These kinds of measures included drug-specific mortality, how lethal a standard dose was, or the propensity for its use to cause related illnesses like cancer or HIV, and also dependence factors, how addictive it was. Other factors looked at harm to others, like rises in crime, the economic burden on communities, or the likelihood that the user would inflict violence or harm on other people. The top 4 most harmful drugs by expert consensus were alcohol, heroin, crack cocaine, and methamphetamine in that order. Although again, in terms of total mortality and morbidity, tobacco still leads as the deadliest recreational drug in the United States. Another way of measuring harm is more simplistic. How many people die directly from use or overuse of a substance in any given year? This chart looks at overdose deaths as reported by the CDC in 2015. Here, the deadliest illicit drugs are prescription drugs used for recreational purposes, i.e., to get high. Together, these kill about 25,000 people annually, and most come from prescription opioid overdoses. Alcohol overdose alone kills about 2,200 people, although if you add in DUI fatalities, that accounts for another 10,000 or so deaths, according to the CDC. Cocaine accounts for an estimated 5,000 overdose deaths. Heroin is responsible for about twice that. At the far right of the chart, you can see one final drug, cannabis, with 0 overdose deaths. No one has ever been documented as having died directly from an overdose of cannabis, but there are potential harms associated with cannabis or marijuana use, most commonly from driving under the influence. Heavy use of smoked cannabis may also have some similar health impacts to those of smoked tobacco. Let's talk about alcohol. Though it is a legal substance, at least for consumers over a certain age, it is still among the most harmful recreational drugs in American society when used in excess or irresponsibly, and a lot of people do use it very heavily. The CDC defines binge drinking as 5 or more drinks on the same occasion within the past 30 days. The same occasion is basically defined as within a few hours, so it's somewhat self-defined. Heavy drinking is defined as 5 or more episodes of binge drinking within the past 30 days. For some of you, That might not seem like a lot of alcohol to qualify as a binge, and that is because a fairly high percentage of Americans engage in consumption patterns that health experts define as binge drinking. 52% of Americans define themselves as current alcohol users. About 22.9%, or a little under a quarter, qualify as having engaged in binge drinking episodes, or one binge drinking episode at least, over the past 30 days, and about 6.3 meet the criteria for heavy drinking within the past 30 days. Some populations use more heavily than others. This CDC data from 2010 look at past month behaviors and finds that among full-time college students, about 59.4% reported drinking, 39% were self-reported binge drinkers, using the same definition reported earlier, and about 12.7% were heavy drinkers. Males tend to consume alcohol at higher rates than females, and consumption also varies by state, with binge drinkers in Louisiana and New Mexico drinking more than Texas binge drinkers, who in turn consume more alcohol than binge drinkers in New York or California. Use rates also vary by race. This chart shows current alcohol use in light blue for all major racial or ethnic groups in the United States, binge use in gray, and heavy use, which is defined as repeated episodes of binge drinking, in dark blue. Whites use at the highest rate of all groups and are more likely to be binge drinkers than blacks. Whites also have higher rates of heavy drinking use than blacks, Hispanics, or Asians, and similar rates to Native Americans. A conflict theorist would point out here that there is no small amount of self-interest at play when the dominant group decriminalizes the drug it uses most, alcohol, while heavily criminalizing drugs that are slightly more likely to be used by other racial and ethnic groups. Remember, conflict perspective holds that privileged groups will tend to structure social institutions to perpetuate their own privilege. Historically, the more a drug becomes associated with poor or minority populations, the more stigmatized or criminalized its use tends to become. Drugs used by privileged groups, on the other hand, tend to be less criminalized or stigmatized. We see this trend when we look back at the history of many recreational drugs. Opiates are a term for a class of drugs that are derived from opium, a substance that is made naturally by a plant, the opium poppy. Raw opium, which comes from the plant's sap, has been used for pain relief, to produce sleep, and for its euphoric effects since prehistoric times in the parts of the world where it grows naturally, namely Asia and the Middle East. Opiates, like morphine, which was first synthesized from raw opium in 1803, were widely used as battlefield anesthetics during the Civil War, and one of the first large and very visible opiate-addicted populations came in the form of Civil War veterans who became addicted to the drug as a result of being dosed with it after injuries. Middle and upper class women were a second population with disproportionately high addiction rates during that era and the later Victorian and Edwardian eras. Opiate medications were prescribed for all sorts of ailments, including quote-unquote female complaints, like menstrual cramps or PMS. Women were also more likely to be diagnosed with nervous disorders and treated with opiates for that reason. This was before controls on the sale or possession of what are now controlled substances, and before modern consumer protection regulations as well, so such medications were commonly compounded into over-the-counter medications, like this cough syrup, which contained alcohol, cannabis, chloroform, and morphine. It is estimated that in the late 1800s, rates of opiate addiction in the general population were about 3 times that of the current era. Opiates were common ingredients even in medications marketed for children. Mrs. Winslow's soothing syrup was about as common as baby aspirin in turn-of-the-century medicine cabinets, and it was very soothing indeed, since the active ingredient was morphine. On the left of this slide, you see an old glass bottle for another bygone product. bare heroin. A lot of women began using opiate medications and syrups to keep children who weren't in pain quiet for long stretches of time, too. Poor women, for example, were sometimes accused of dosing babies with it to make them sleep during the long hours when they had to work. This caused the dual health crisis of overdose deaths in young children, as well as a generation of children who likely battled the symptoms of addiction and withdrawal from very early ages. Cocaine, which is derived from the coca plant, which is native to South America, was first synthesized in its modern form in the mid 1800s and began being used medicinally in the 1880s. Cocaine was initially touted as a near wonder drug that could cure anything, from asthma to indigestion. It also came into common use as a way of curing morphine addiction. The most famous historical application thereof came in the form of Coca-Cola, which was invented by a man named John Pemberton, a Civil War vet and a morphine addict who had begun experimenting with cocaine as a way of treating his symptoms of withdrawal. Eventually, he combined cocaine syrup with African cola nuts and began marketing Coca-Cola, first as a patent medicine and later as a soft drink. Sigmund Freud was a frequent cocaine user, as was Arthur Conan Doyle's fictional detective Sherlock Holmes. Freud claimed cocaine was a completely safe treatment for his bouts of indigestion and depression, and it probably did help with his depression, as it is a euphoric stimulant. It was also eventually added to a range of products, including patent medicines, margarine, wine, and of course, Coca-Cola. Cocaine, by the way, was removed from Coca-Cola in 1903. Initially, opiates and cocaine were more likely to be abused by economically privileged whites. In fact, they still are. But over time, as people of more racial groups and social classes began to get access to these substances and overall addiction rates rose, they started being seen as less socially acceptable. The earliest attempts to criminalize these drugs used stereotypes about poor, non-white users to justify legal crackdowns. Again, this is important because it's a trend that we still see today. The more a drug is associated with poor and minority populations, the more likely its use is to be treated as a criminal offense. The more it is associated with upper class populations, the more its use is either framed as a lifestyle choice, or in some cases, a disease. This article, published in the New York Times in 1914 by a Dr. Edward Huntington Williams, argued that cocaine needed to be controlled in the U.S. because it was becoming heavily used by quote-unquote Negroes and had particular effects on them. Specifically, Williams believed that cocaine made blacks especially aggressive, immune to shock, and also temporarily immune to bullets, as well as steadying their nerves and turning them into expert marksmen. Arguments made by people like this worked. In 1914, Congress passed the Harrison Narcotics Tax Act, which put some controls on who could sell and import opiates and coca leaves and levied higher taxes on them. Eventually, permission to manufacture, sell, import, or prescribe opiates and cocaine-derived drugs was limited to registered pharmaceutical companies and physicians. It wasn't just non-white minorities who became associated with the use of stigmatized drugs. Many new European immigrant groups in the turn of the century era were heavily stereotyped as drunkards. One reason for this was that many new migrant groups came from Catholic-sending countries, where social consumption of beer and wine were more common and acceptable. Protestant Americans were more likely to be suspicious of drinking, and many Protestant denominations forbid it outright. New Irish, Italian, and German neighborhoods ended up poor and overcrowded. Essentially, they were slums or ghettos. They generally had higher rates of crime, both because they were poor and because new arrivals tended to be young, working-age men who are more likely to do things like drink to excess and get into fights. Social reformers looked at conditions in the slums and said, these rowdy Irish, Germans, and Italians, they get into so much trouble because they're all drunks. We're going to put a stop to that. Germans in particular became a target of hostility after U.S. entry into World War I in 1917. Germans had come to be associated with commercial beer brewing in the United States and were well represented among saloon and beer garden owners. Drinking in halls or beer gardens was a mostly German tradition that had been imported. Some anti-German public figures alleged, without evidence, that German-American brewers were being secretly funded by the German Kaiser, the German government, as a way of keeping America drunk and destitute, as in this political cartoon, where Germans are represented as beer barrels and the German Kaiser is shown pinning a medal on one. During World War I, boycotting or shutting down brewers was framed as a patriotic act. This push to outlaw alcohol, by, in some cases, tying it to immigrant lawlessness or sabotage, eventually led to Prohibition, or the 18th Amendment to the U.S. Constitution, which prohibited the production, transport, or sale of alcohol. It didn't work so well, and led to massive increases in alcohol smuggling, called bootlegging, and a boom in organized crime. Prohibition was finally repealed with the 21st Amendment to the U.S. Constitution in 1933, about 13 years later. Marijuana use had similar associations with marginalized minority groups. One of the leading figures behind the push to criminalize marijuana was a man named Harry Anslinger, who was the first commissioner of the Federal Bureau of Narcotics, an early precursor to the DEA in the 1930s. Anslinger was a pretty open racist, and he was very forthright about his belief that marijuana was particularly dangerous because he thought it made blacks and other minorities get above their station or above their place. Or as he put it, reefer makes darkies think they're as good as white men. Even though marijuana and hemp were cultivated in the United States since colonial times, recreational marijuana smoking eventually came to be associated with early waves of Mexican migrants, and some did smoke the drug recreationally. Concern about the drug became tangled up with fear and prejudice about the Spanish-speaking newcomers, especially during and after the Great Depression, when joblessness drove an increase in anti-immigrant sentiments. Anti-drug campaigners warned against the encroaching marijuana menace and terrible crimes that were attributed to marijuana and the Mexican people who used it. By 1931, 29 states had outlawed marijuana or cannabis use. Sale and use of marijuana were effectively banned nationally in 1937. Crackdowns on the use of certain recreational drugs didn't end with criminalization, though. In the 1970s, under President Richard Nixon, the U.S. launched the so-called War on Drugs, a legislative push spurred by worries about heroin addiction rates among returning Vietnam veterans, an increasingly visible quote-unquote hippie drug culture, and fears that drug abuse would weaken the United States' ability to fight the Cold War against Russia. Policy changes included the creation of the DEA, the Drug Enforcement Administration, and changes in sentencing laws, as well as more federal funding for drug treatment programs. The Nixon administration also reclassified marijuana as a Schedule I drug, categorizing it with heroin as a drug with high potential for addiction or abuse. One reason for that is that advocates of marijuana criminalization maintained that it functioned as a quote-unquote gateway drug to the use of harder drugs like heroin or cocaine. Legislative crackdowns on drug possession, such as the passage of mandatory minimum sentencing laws like the Anti-Drug Abuse Act of 1986, are one factor that criminologists use to explain the explosive increase in our incarcerated populations after 1970. In fact, even as overall crime rates began to fall after 1996, the imprisoned population just kept going up. This is a trend that has hit minority communities particularly hard. Although blacks and whites use at similar rates, blacks are more likely to be arrested for drug crimes than whites. This graph, which is admittedly a little hard to read, was published by the Washington Post in 2014. It breaks down incarceration rate increases by age group, shown at top, and by race and education level, shown by the colored lines in each graph. From 1960 to 2010, you can see the staggering rise in the incarceration rates for black men with no high school diploma, shown in dark purple, across all age groups. Incarceration rates also rose for all black men, light purple, white men with no high school diploma, dark green, and all white men, light green. though not as dramatically. On every given day in 2010, almost 1 in 10 black men ages 20 to 39 were incarcerated or under some kind of correctional supervision. Drug use patterns follow trends and fads like anything else. While overdose deaths and general youth stats of other drugs like cocaine have remained pretty constant, and those of other drugs like methamphetamines seem to be decreasing, one disturbing trend is a really noteworthy spike in the number of prescription opiate deaths over the last decade. They've tripled since 2000, and a corresponding rise in the use of heroin. Up until the 2000s, heroin was sort of passé. It was a drug from an earlier era, like opium, that seemed almost quaint in the midst of fears about drugs like crack and crystal meth. But it's seeing a huge resurgence now. In the 1960s and 1970s, heroin was also associated mostly with inner-city, low-income, and minority communities. Now, we see heroin addiction, and opiate addiction more broadly, surging in white communities in particular, often among middle and upper-class users. You've probably heard some about this opioid or opiate epidemic. But why did it happen? Social problems don't usually come out of nowhere, and this one is no exception. A number of factors drove the spike we're currently seeing in the abuse of prescription opiates, and they have their root not in the back alley drug trafficking networks, but in the legitimate medical community. One was a trend among doctors, and it wasn't necessarily a bad one. By the 1990s, doctors and medical researchers had begun to pay more attention to pain, not just as a diagnostic symptom, but as a pressing medical issue that needed to be addressed in its own right. A growing body of research suggested that patients of all ages were being chronically undermedicated for pain and were being made to suffer unnecessarily as a result. That was probably the result of medical colleges, still influenced by the major epidemics of opiate addiction at the turn of the century, teaching medical students for generations to err on the side of extreme caution when it came to prescribing opiate painkillers. With growing research in the field, physicians began recognizing the deleterious physical and psychological impacts of untreated chronic pain. A major piece of this was a study published in 1986 that was incredibly influential but based on flawed research. The authors, Portnoy and Foley, argued from a sample of 36 patients that while recreational users of opiates easily became addicted, a patient who was in actual pain really couldn't. As long as there was underlying pain, they argued, it muffled the euphoric effects and the patient couldn't become addicted. They estimated only 1% of all patients who took opiates for pain, even at high doses and for long periods, would get addicted. There were a lot of problems with the study. For example, it had a small sample size, and really only looked at people who were hospitalized for short-term treatment following surgery. But it ended up being widely influential. Pharmaceutical manufacturers of pain medications in particular were very enthusiastic about the finding, and began heavily promoting the research to get physicians to more readily prescribe their products. The next step toward the epidemic happened with the release of OxyContin, a form of oxycodone. The drug oxycodone is an opium derivative, first synthesized in 1916 by German pharmacists who were looking for an effective painkiller substitute for heroin in light of rising awareness that heroin was massively addictive. Unfortunately, oxycodone wasn't the solution. It relieved pain great, but was just as habit-forming as morphine or heroin were. It went to the market anyway, and according to surviving diaries of his physician, Adolf Hitler was a heavy user, probably an addict. In 1996, Purdue Pharmaceuticals announced their own formulation of oxycodone, a drug they called OxyContin. OxyContin was different, Purdue argued, because it was compounded into a 12-hour slow-release pill that was supposed to keep patients from getting the initial euphoric rush and then ensuing crash. Because it was slow-release, Purdue claimed it was virtually addiction-proof. Pharma reps and companies began heavily marketing the drug to doctors, who began heavily prescribing it to their patients, believing their old fears about spawning an addiction were over. Purdue supported this trend by funding a lot of research that seemed to back up their assertions that OxyContin could not be something that would lead to an addiction. Unfortunately, Many oxy users immediately discovered that you could get around the time-release formulation by crushing the pills into a powder and then snorting or injecting them. Because there was such big money in opiates, a lot of so-called pill mills popped up all over the United States. These were pain clinics that made money by employing doctors who would write large scripts of opioids for pretty much anyone who asked for them. This fueled the epidemic because once patients' own doctors recognized their addictions and cut them off, they would simply turn to pill mill pain clinics instead. Even that wasn't a long-term solution, though. The FDA began cracking down on pill mills, closing many, and serious users often eventually lost the jobs in health insurance that allowed them to get opiates via prescription anyway. When that happened, many turned to street drugs like heroin, which is far cheaper and usually gives a similar high. But as the number of white and middle-class opioid addicts grew, we did see the resurgence of an old trend. Whereas crack addicts, for example, were framed as hyperviolent, dangerous criminals, opioid addiction is more likely to be medicalized than criminalized, and opium or opioid addicts more likely to be framed as sick by the media and politicians rather than as deviants or criminals. In 1989, at the height of the crack epidemic, President George H.W. Bush said, "We need more jails, more prisons, more courts, and more prosecutors." Now that opiate use is skyrocketing and most affected individuals are white, one is more likely to hear expressions of sympathy and promises of help. The Trump White House has, for example, declared the opiate epidemic to be a public health emergency. A statement on whitehouse.gov notes that defeating this epidemic will require the commitment of every state, local, and federal agency. Failure is not an option. Addiction is not our future. It also pledges to honor the memory of those lost to addiction with action and determination and resolve. This distinction is not just a rhetorical one. When a society frames drug use as a crime issue, this creates what we call prognostic frames that suggest punitive solutions, harsher sentences and more prisons. Framing drug use as a health crisis suggests different prognostic frames. Only criminals go to prison after all. Sick people go to hospitals, counselors, or rehab centers. Rather than punishing people who are drug users, some public health advocates argue that the use of some or certain illicit drugs should be either legalized or decriminalized. These are different things. Once a drug is completely legalized, it creates new markets for legitimate entrepreneurs and usually expands access, so you can see the number of users increase. It also allows for governments to profit through levying taxes off the sale of that drug. Usually, it opens the door to government oversight and regulation. The product, for example, will usually become safer, as alcohol did after Prohibition, and the government may and often will get into the business of issuing licenses on who can sell, grow, or distribute the product and under what circumstances. Decriminalization is kind of the murky middle between outright prohibition, what we mostly have with illicit drugs now, and total legalization, i.e. marijuana or cannabis in some states. Critics call it the worst of both worlds because it still leaves drug production and sale in the hands of the criminal underworld, but gets rid of one of the primary resources society has to discourage drug use, namely the threat of punishment. Also, the government can't regulate the product or tax it. Many countries who have tried decriminalization have basically decriminalized simple possession and use, but continue to criminalize sale and production, thus allowing the police to focus on the bigger fish, the traffickers or the dealers, and allow personal users to escape criminal prosecution. Advocates for decriminalization of hard drugs like heroin or cocaine argue that the United States might try the strategy pursued by Portugal, which decriminalized all drugs in 2001. It's still illegal to sell or traffic hard drugs in Portugal, but being caught with small amounts now results in referral to a drug treatment program, not a criminal charge or jail time. In light of the fact that little existing evidence supports earlier assertions that marijuana acted as a gateway drug to harder drugs, or that it had any of their negative effects, and cognizant of the fact that its use does have some medical benefits for some conditions, and that criminalization of cannabis is a drain on police resources and may lead to increasing rates of incarceration, many states have begun decriminalizing it either for medical use or for recreational use, or in some cases, outright legalizing it. At the time of this recording, 25 states allow the use of cannabis for certain medical conditions, and some states, led by Colorado and Washington state, have legalized marijuana for recreational use by adults. This unusual photo is from the Seattle police initiative called Operation Orange Fingers that distributed bags of Doritos at Seattle's Hemp Fest after the new law legalizing marijuana went into effect. The Dorito bags had stickers on them informing recipients about the do's and don'ts of marijuana use, such as no driving under the influence and no use by people who are underage. This concludes this lecture on alcohol and drug use. Thank you for listening.